actually Egyptians had used electrical stimulation over 4,500 years ago, and even the Greeks and Romans had used this. And that involved the use of a torpedo fish to really help ailments, things like gout, things like migraine. Because they found that if they were stimulating folks in these different painful areas, once the fish was removed, that they would have this numbing sensation, and the numbing sensation was actually felt good, right?
Felt good.
No more pain, right?
Yeah.
So I think it dates back, but I would say that we've significantly refined it.
Sure,
yeah. Today, yeah.
Welcome back, everybody, to another episode of BIOS KOL Sessions. Today we have our very own Dr. Charles DeMesa. Thank you for being here.
Thank you very much.
Appreciate your time, of course.
Yeah.
Today we're going to be diving deep into the world of neuromodulation. We're going to split it into two halves, the first being spinal cord stimulation and the second peripheral nerve stimulation. So I'm very excited to learn more about this topic. We have one of the world's experts here, so let's dive right in.
Sure.
Tell us a little bit about your background and how you got started with the neuromodulation.
Yeah, so I'm pain trained, and I was fortunate and grateful to be trained under Dr. Paul Kreese, Samir Sheth, and Naleshni Singh over at UC Davis.
Nice.
They have produced some of the foremost in terms of academic pursuits as it pertains to spinal cord stimulation, including neuromodulation by Paul Kreese, and a second edition by Paul Kreese and Dr. Pritzloff, Scott Pritzloff, as well as Dr. Copenhaver. So very, very thankful for being able to be mentored by.
That's a great crew.
Yes.
Yeah, I'm sure you've learned a lot of clinical pearls, and it's interesting how it is, right? You pick up a little bit from each person, right?
Yes.
Good, bad, or indifferent. You always are learning kind of these different little pearls from the different mentors. Well, let's talk a little bit about, spinal cord stimulation. Obviously sounds like an intimidating procedure. Who is the right patient for this? When people come in, obviously you see back pain all the time, but who is that patient that says that you go, okay, we're going for neuromodulation here?
Yeah, that's a very good question. I would say a lot of times those folks with neuropathic pain seem to be very good candidates.
Yeah.
Those with very defined, lesions, so for example, unilateral radicular pain, although it's also used for axial low back pain as well, but very discrete nerve elements and dermatomal patterns. Those patients that perhaps have had surgery and have evidence of epidural fibrosis or scarring along the nerve. People with arachnoiditis, for example, complex regional pain syndrome. These tend to be those folks that respond very well to the treatment. There are others, but mainly neuropathic pain as opposed to just simply nociceptive pain. Yeah.
And where is this, in terms of the spectrum of care, right? Is it somebody who's, just has a disc herniation, they have a radiculopathy? Do they have to fail typical treatments like physical therapy, epidural steroid injection? When do you go straight to something like neuromodulation?
Yeah, it's a very good question. Thank you, Alberto. I think a lot of times we look at utilization of healthcare, but then also the natural course of a specific condition. So for example, of disc herniation, sometimes those discs can resorb. And, sometimes they stay the same, sometimes they get worse.
Sure.
And so in this treatment paradigm, we have to carefully consider those things as well. And so things like physical therapy, quality physical therapy, injection treatments may afford benefit. And so spinal cord stimulation may not be that early on for some folks. Some people do practice that and use it early on in the algorithm and paradigm. And that is, it's not necessarily a bad idea, but it is a costly procedure. And if you look at it in terms of standard medical practice, in that light early on, it may not be as cost effective. When you're comparing it against things like reoperation, then you're looking at not only patient satisfaction, improvement in outcomes, but also cost effectiveness in comparison to post-surgical. So I personally reserve it a little bit for those defined conditions that I've mentioned. And then, more and more I look at it in terms of how will it impact the patient's quality of life years missed? Because when they're not able to perform, when they're not able to be at work, when they're not able to be with their families, that becomes, a cost in and of itself, a very important cost.
Absolutely. Yeah, and neuropathic pain is, I mean, just debilitating, right? It's a very difficult problem to control. I think the way I've seen it used is, like you mentioned, definitely post-surgical patients, post-laminectomy, post-fusion that are still continuing to have neuropathic symptoms. And I think because it is an implant, we try to do as much as possible until, hey, there really is not another choice.
Yeah.
All right, so tell us a little bit about the trial itself, right? Because, to give a little bit of a heads up, the way that this works is we do a trial, right? There's not a permanent lead placed. And depending on the results, then you're now a candidate for the permanent placement of the stimulator. So tell us a little bit about that.
Yeah, so there's certain things that occur. Before that even, there's even a psychological assessment. So what we tend to do is we have to make sure that the patient understands and has reasonable expectations of what they're getting into. And a lot of times patient selection is key. So we mentioned some of those elements of people that would seem to be good candidates for therapy. Additionally, we want to make sure that there's no undertreated psychological impairment, schizophrenia, things like depression and other things that may create issues with the patient, dementia, et cetera. Also that they have reasonable expectations. They know what the therapy is about. They know that it's not an end-all, cure-all. They also have to understand that they will be living with a permanent device potentially in their bodies. And finally, they need to understand that they may need to have adherence to post-implantation care. And those include things like attending reprogramming visits, using and adjusting either an app or a remote to help improve their pain over time.
Got it. So the patient comes in, what is the procedure like?
So
They've probably already had experience with an epidural steroid injection.
Sure.
Like, how does it compare to, the traditional injections versus like this is more of a procedure? Or is it very similar?
Yeah, it's very similar. So it almost is like a glorified epidural, if you will.
Yeah.
Importantly, we do take every precaution to make sure things are safe. So that includes, sterile technique. It includes assessing the MRI in both views, checking for the epidural space, minimizing any risks. But essentially what it is placing a cannula, if you will, right close to the entry point of where the epidural space is. The epi means above, dura is a tough covering that covers the spinal cord and the meninges. It is one of the meninges. And so we essentially place these leads. Leads are just basically a cylindrical polyurethane threads, if you will, that have electrodes at the very tip. And so we shoot these threads all the way up behind the spinal cord, on the dorsal column of the spinal cord. Dorsal just meaning back, and column means the interior toward the midline, because that's where a lot of the activity occurs. And so we place this through, and then basically we remove the cannula through which that lead was placed, and often we place two. And this is all done under fluoroscopic guidance, so we can actually see where things are going and how they are going. We also ensure that the patient has good sedation or anesthesia if needed. And ultimately, basically just connecting that to an external pulse generator. And they use this and they wear this for about 5 to 7 days. They carry on with their activities. No significant bending, lifting, or twisting, because we don't want the leads to migrate too much. However, they are encouraged to do their activity. And the goal is to see how well they do. Are they sleeping better? Are they functioning better? Are they walking longer? Are they in less pain? And the threshold typically is at least 50% pain relief. We also look at reduction in medications. I talked earlier about neuropathic pain states. Another very useful application is in diabetic peripheral neuropathy and other peripheral neuropathies. And so are the medication uses going down? Things like the gabapentinoids or the other membrane stabilizing medications, Norco, or other opioids that people tend to use. Are those decreasing? These are all elements. And when that occurs and we are able to see that they are in fact improving, do we decide to go to permanent implantation?
Got it. And from a technical perspective, do you like to go, is this an interlaminar approach? Is it transforaminal?
Yeah.
You know, what size leads do you use? Kind of what's your approach in attacking that?
Yeah, so you know, the leads are fairly standard. The approach is an interlaminar approach predominantly. And I might add that spinal cord stimulation, there's also spinal column stimulation. So not only can you stimulate right into dorsal columns, but there's another entity, it's called dorsal root ganglion stimulation. And the thought of transforaminally, if you were to think about the foramen just means hole. And so if you look at the side foramen, the neuroforamen, that's where the dorsal root ganglion lives. And that dorsal root ganglion then, you know, attaches to and communicates with the spinal cord. So one can actually shoot one of these leads up and go through toward those neuroforamens. That's dorsal root ganglion stimulation. It's very specific for a discrete dermatome. It works wonders for things like complex regional pain syndrome. So nevertheless, that still is entered, you know, interlaminarly and placed mirror window from a transforaminal approach.
Okay.
So very interesting, but all spinal cord stimulation tends to be interlaminar in its approach. Then we start thinking about it, and I think this is what the point you were getting to is, well, where do you place the leads?
Yeah,
right? Like,
absolutely.
You know, like, and predominantly a lot of people that have, you know, either peripheral neuropathy or failed back surgery syndrome, or you know, they have arachnoiditis or other things, they'll have burning pain in the legs. And so, you know, the way that the somatosensory cortex is in terms of the brain, there's a map, and very much so the spinal cord has its own somatotopic organization. Soma from the Greek body, topos also, you know, it's of a certain region. And so there is a element of how that how the back part of the spinal cord is organized. And those things that are represented higher up tend to occur and arise from root fibers that are higher up, and those that are lower down, they're represented more toward the midline. So upper is kind of lateral, lower is kind of midline, and therefore most of the targets, irrespective of the system, tends to be in the thoracic region, typically from T9 to T11, for example, would cover things like L2 to L5, so lower down.
Got it.
So you have to put it higher up in order to help. And it has to be somewhat midline if we're trying to achieve relief of the back and the lower limbs.
Got it. So is it safe to say that spinal cord stimulation versus dorsal root stimulation, dorsal root is a very kind of a specific channel of pain, versus spinal cord, there's diffuse neuropathic pain through the limb? Is that accurate, or am I overgeneralizing?
It's a good estimate. I see your point, and it's important to understand that there's, on face value, yes, it is the case, but it's a little bit more complicated than that, because even successive dorsal column, or I'm sorry, different dorsal root ganglion can communicate, in fact. But what's very fascinating is that if you have CRPS of, say, one limb, and you do stimulate on that limb, sometimes people, you know, the CRPS spreads somewhere else. Wow. But if you were to target those specific areas, right, like we have people that may have hernia pain from post-hernia RFB pain, and then ultimately you could do DRG stimulation for that. Or people that have maybe big toe pain because they had a bunionectomy surgery or something of that matter, and then you could stimulate, say, L5 for the. So you can actually treat those singularly and help that. And even if it affects other limbs, it can reduce in terms of its intensity, and people have actually gotten better. So pelvic pain, you could do a target for that, right? Pudendal. Nerve rootlets that go towards the pudendal distribution. So these are all elements where, yes, you can have it singularly, but it seems to help overall, even if people have maybe a chronic widespread pain that starts to emanate. However, I would caution that most spinal cord stimulation, the best avenue is for discrete pain. and very refined neuropathic pain, as opposed to diffuse pain syndromes.
Got it.
Things like fibromyalgia, probably not going to be very beneficial
Okay.
for that.
That makes sense. Now, during the trial itself, can you, once you put the leads, are you testing it right there on the table, or how does that part go? Right, the lead has been placed. What's next?
It's a good question, and so oftentimes people who are pragmatic, they will like to test, and the reason is because they want to make sure that there is some form of tonic stimulation in the distribution of where the patient is having pain. And so if it is overlapping that area, that's a good signal that by and large we have good placement and we can proceed with a good trial. Nowadays the programming, is such that as long as we have radiographically, lead placement in the appropriate areas, that's sufficient. But
Okay.
a lot of times, we just check and make sure that the impedance levels are good, like all things are go and all things are checked.
Got
And
it.
a lot of our very helpful clinical representatives are always right there with us in the
Yeah.
room, making sure that is the case before we exit.
How painful is this, right?
As my mentor, Paul Kreese said, I didn't feel a thing at all.
Yeah.
But what I would say to you is that for the most part, if we go by those important factors that we can control as as implanters, then we can minimize any pain. So for example, just something simple as putting local anesthetic, right? Are we actually placing the local anesthetic, giving sufficient time waiting before we create an incision, As we're entering that, like you mentioned earlier, the interlaminar approach, lamina it's os, right?
Yeah.
So when you hit os, it can hurt, right?
Sure.
So are we placing a little bit of lidocaine right there in the os just to create a little bit of laminar flow right along that region before we touch and we start moving off of that area and entering the epidural space or
Got it.
placing that, getting the loss of resistance and getting into that area. It's very, very comfortable if you have all of those things in place. And the more the patient knows in advance, the easier it is for them to
Got it.
tolerate the procedure.
All right. In terms of specific features, obviously there's a lot of different devices. What are your preferences? What do you like in terms of waveforms, burst stimulation, closed loop? Guide us a little bit into how you go about thinking those things.
I liken it to, and this is one of my my fellows brought up, a very brilliant gentleman, Ammon Hill. He always talked about like, hey, there's different recipes for a barbecue competition.
Yeah.
And so, you have some people like a little heat,
Sure.
some people like it a little bit sweeter, and so forth. And the reality is that there is a broad level of menu options for which patients respond to.
Yeah.
And for some, it still yet is the traditional, what we call tonic stimulation. And these are having a variety. So that's like you actually feel the stimulation in the area of where you have pain. So that's one example of one waveform. Another type of waveform is a burst stimulation, right? So this is pulses or sequences of 500 hertz every 40 seconds, and it repeats. So it sort of mimics what the normal nerve networks behind the spinal cord sort of operate at that level. And so that creates relief in some people. And then there's even things like differential targeted multiplex, where it's various forms of frequencies that mimic not only neuronal cells, but also glial cells. Glial cells are very important because they are support cells for the central nervous system. And so when you're looking at a more of an amalgamation of helping just the overall well-being of the spine, some people do really well with that type of treatment.
Got it.
By and large, I think our movement, as people start thinking more about AI and technology and all of this, is closed loop, right? Like you want feedback,
Yeah.
Students want feedback, fellows, residents, they want feedback from their attendings, vice versa. And in any temperature controlled area, you kind of have feedback, so you know what the current temperature is, and it can change and adapt with those changes. So there is this concept of closed loop, which is very helpful because stimulation, a lot of its limitations occurred when people were moving, right? So if you imagine those leads that are in the back, they have to stimulate the dorsal column. Well, there's cerebrospinal fluid that separates those leads from the spinal column. So when you're sitting up, you're laying down, you're bending over, those stimulation patterns will change with movement. So people move towards accelerometers to kind of see, hey, if I'm up in this position or down in this position, maybe some benefit there. But with closed loop, it's now receiving information and understanding where activity is occurring in the spinal cord and adapting to that and changing it real time. This way you have a consistent current that's delivered so that people could get maximal pain relief.
Got it.
So I prefer sort of the adaptive, the stimulation closed loop, if you will, for those reasons stated.
So if we break it down to very just layman terms, what is spinal cord stimulation? Is it, I've heard the example of, let's say that there is a noise that is bothering you. So you're basically turning on a noise that you like and turning the volume up so you no longer hear the bad noise. Is that something to apply here, or kind of how do we break it down to very simple terms?
Yes, and yes. So that is the starting point, I would say. And that largely comes from what's called the gate control theory of pain. And so if you think about our bodies, we have a lot of neurons, right? And we have a lot of receptors, and pain typically when it's processed, it occurs through 4 pathways, right? So you have transduction, transmission, modulation, and perception. And through, for spinal cord stimulation, the modulation occurs at that 3rd phase. In terms of what you were mentioning earlier, a lot of times when you stimulate some of those faster, myelinated, that means the nerves have actually a coating around them that allows the nerves to propagate faster. If you're stimulating those nerves go first, and the other nerves, if there were a gate to control pain, the other nerves like A delta and C fibers, they're either lightly myelinated or unmyelinated. So they travel a little bit slower, the delta a little bit faster than the C fibers, which are even slower. So they don't get a chance to get through. And so you basically blocked their ability to be transmitted and
felt as pain
and perceived as pain.
Got it.
So that's rudimentary, actually. Because that's only one little piece. Our understanding is so dynamic because there's ascending pain pathways and there's descending modulation, descending modulatory pathways. And what's very fascinating is that this all occurs in different areas and processes within the central nervous system. So we're talking about the spinal cord, the dorsal column, to the thalamus, the anterior cingulate cortex, and even the prefrontal cortex. What's very interesting is not only are these areas where pain processing takes place, they are also the areas where things like emotions or fear, and anxiety, for example, may take place. And surprisingly, even some of these locations are for spirituality. And essentially, if you are able to interrupt the signals and ameliorate and make things better, mood can get better. And that's what we've seen is that even there will be studies looking at, hey, spinal cord stimulation for things like depression and the like may be coming out. Now, suffice it to say, in Europe, what this is also used for, and I'm getting to the explanation of mechanism, right? There's more to it than just the gate control theory of pain. There's the modulation from a descending route. There's also modulation in terms of angina type pain. Could you imagine, like vasoconstriction dilation? And so we see this as an amalgamation of not only what's gate controlled, but also things like with descending modulation, GABAergic kind of things, serotonin, relay centers, and so forth.
Okay. So we've placed the implant, right? Everything looks good. Tell us about the post-programming, or basically the temporary implants in. What happens immediately after?
So after the temporary, let's just say it's a person does in fact get good relief for the trial, we remove that typically in office or in the procedure center where the physician is. We apply a Band-Aid, and we try to get the person to have their implant as soon as we can, right?
Yeah.
Because there's a delay sometimes, and that's not always good. We want to make sure that
Sure.
they receive the treatment and they start getting therapy as soon as possible. After that, the permanent implant involves, number one, placing the leads again, and then creating a little tunnel, and then placing what's called an implantable pulse generator. So that's
Okay.
what creates the ability for the leads to function and provide
Got
that
it.
electrical conductivity. So that's all done all on the same day. And we do check back with the patient. We want to make sure and check for the wound, make sure there's no evidence of infection. And we're very careful about that. For both the trial and for the implant, we do run antibiotics.
Got it.
And we follow a set of guidelines from our pain guidelines. And after the patient is restricted from bending, lifting, twisting for
Yeah.
a certain degree of time, usually about 6 weeks for sure. And we want those leads to hold in place. That said, it's very important that the physician really understand what they're doing, right? We really need to anchor, perform solid techniques
Sure.
to ensure that the patient gets the best outcome. After that, we still continue to program. And you may ask the reason why do we continue to leverage and be near and dear to
Yeah.
our clinical representatives. It's because even though there's closed loop, even though there's stimulation, we have to understand that fibrosis sets in. So fibrosis, if you think about leads or any foreign body that's in your body, there will begin to have scar tissue that forms around it. And those can form around leads.
Yeah.
Some studies have actually demonstrated that up to 26% of fibrosis does occur along a lead, and that can occur every 3 months. So if you're talking 25% every 3 months, by a year, there could be significant fibrosis, right? So it's very important that, and I think we have seen this occur where some folks, they'll just say, oh yeah, I had a spinal cord stimulator a year, 2 years now, didn't work, didn't help me, and I think there's some element to that, but there's also this other element of care and reprogramming, checking in, seeing, changing the stimulation based on the fibrosis or the
Got it.
changes that occur. And then even something as simple as maybe the battery is just, it needs to be replaced after a certain period of time.
Okay.
Yeah.
So just to confirm, the trial itself is 3 days,
5 to 7.
5 to
typically.
7 days.
Yeah.
So it's longer than I expected.
Yeah.
And then what are the parameters during those 5 to 7 days? Are they constantly, programming, reprogram, trying to fine tune? And sorry to interrupt. And then what is you said at least 50% pain improvement. Do people get more or less, or what's the kind of the cutoff?
Yeah, it's a very good question. So I would say to you that a couple of things. Number one is that the clinical representative and the physician, should be in contact with the patient nearly on a daily basis. And usually we receive feedback from the clinical representative as well. And so usually the stimulation is either, depending on the type of waveform used and the company used, you can either increase or decrease stimulation. Some people would prefer not to even turn it on just after the first day and wait until a couple.
Interesting.
They want to wait till the post procedure pain
is
eliminated before they begin.
That's smart.
Yeah. So these are certain elements of care, and for most people they'll be early responders. Most people will respond, and that's important to get a sense of how you're doing. So we want them to be active during the 5 to 7 days. So I would say to you, number one is, yes, there's a close understanding and interpretation and a sense of what is the percentage pain relief, what am I able to do better, and importantly, am I able to reduce my medications even?
Sure.
And that's really that's heartwarming when you have somebody who maybe they have diabetic peripheral neuropathy and they've been using so much, like pregabalin and then they say to you, oh boy, I was able to reduce this by 50%, meaning my medication use.
Yeah.
or I was able to eliminate it during this period of time, those are very, very helpful indicators
Sure.
of a successful trial.
Great. So, all right. So we're going to skip forward a little bit. I passed the trial. I got the implant. Let's just say I'm very happy. I have, 85% pain improvement. My quality of life is much better. I'm no longer taking opiates. Is that permanent? Right? Is that 85% relief going to be sustained forever? Is it going to decrease over time? What happens next?
I would say that can change, and I think for several reasons. One is neuroplasticity. The body can change. As we age, things change over time. Two, I mentioned earlier the fibrosis.
Sure.
That could set in, and that can result in decreased efficacy. Lead migration can occur.
Okay.
Maybe they're exposed to some sort of lithotripsy or shortwave diathermy, and then all of a sudden the device fails, right? So these are all elements that one has to be cognizant of. So I would say to you, while it is feasible that a person can continue to do well at that 85%, it's not always the case.
Got it.
That said, I think the advent and the advances in technology have greatly improved spinal cord stimulation in this day and age. And I think, Purcell said it best, and there's this thought of a dose separates a remedy from a poison, right? Yeah. And so you have to understand with, it's getting a quality like program or stimulation in the right patient at the right time, through time, in epochs of time as things move along. And so importantly, that is an important component, and that's why closed loop is very, very helpful, because it's receiving feedback, right? And you can understand that. Additionally, I think what has always long been a limitation in terms of whether or not one would implant or not, and I say this because I think it's a very common thing as people travel more, and we're going in different places, and as the United States Preventative Task Force, now we're starting to see that cancers are occurring earlier and earlier. And so, for example, colorectal cancer, when colonoscopies were recommended at 50, they're now at 45, right? And then breast cancers, for example, mammograms recommended at 50, now it's 40.
Yeah.
So earlier detection, which means that there are a lot of people that are going to need imaging.
Yeah.
And that means MRI. So a lot of people are going to have MRIs. So people need to understand that many of these systems are MRI conditional as opposed to MRI accessible.
Right.
And that becomes an important feature of SCS as we advance is can the person be scanned is an important concept.
So all right. So to clear, to make the point there, if you have a spinal cord implant, a lot of them are not MRI compatible. You can't have any more MRIs. Or what other limitations are there?
So I would like to
lithotripsy, you said.
Yeah, so good. I'm just going to back up a little bit, because this is an important concept. Is they're maybe not MRI inaccessible. Some used to be, but they are MRI conditional.
Okay.
But there are some other some other companies on the market where they are in fact MRI accessible, meaning you could do 3T Tesla, you could do so you're
do you have to turn it off, or you have to reprogram? What's kind of the process?
Yeah, so some are it's just everybody comes with a card with specifics, and people in the radiology group, they're able to see what parameters are allowable.
Got it.
So in some cases, some people may need to turn things off, but in other cases, it's just accessible. They're able to utilize it. But again, it really depends on the company and the package insert and how to go about doing that and the type of MRI that can be used. So I think that has largely been a game changer. So that plus the closed loop plus the dosing of and the ability to change what kind of waveform is necessary for that patient at that point in time. So but limitation, getting back to what your point is, I'm sorry to
kind of run along there. That's what we're here for.
But so limitations are things like if you're going to get things like shockwave or shortwave diathermy. If you're a scuba diver, an avid scuba diver, you may not be able to go beyond a certain threshold. if you receive hyperbaric oxygen therapy or things of that matter, that might be a contraindication as well.
Okay.
If you have, many people have hearts, so just like you have pacemakers for the heart, you have
Yeah.
pacemaker for the spine in terms of spinal cord stimulation, you're thinking about, is there a compatibility to that too? So it's not a clear no. It's
Sure.
just making sure that things are squared away
And the patient understands.
and the patient understands that.
So, obviously we always talk about evidence-based medicine, right? What are maybe some of the key papers or, some evidence that says, hey, this works, how good does it work, and how long does it last for?
Yeah, I mentioned that text. I really like that text because it's easy reading
Yeah.
from Paul Kreese. But there are, there are papers from North and Kumar, and we'll have them on the link there,
Yeah.
which looked at, post-surgical or what we call failed back syndrome, and they looked at reoperation versus spinal cord stimulation. And as I mentioned earlier, quality of life improvement, decreased pain, and cost from a healthcare
Yeah.
perspective. And that's
That's
why
great.
largely, companies are covering it
Sure.
for these reasons.
It's a widely accepted
It's
technology.
widely accepted. It's
yeah.
been done now for over 40, almost 50 years.
Wow, I didn't know that long.
Yeah. Well, to be clear, actually even earlier, did you know, Alberto, that actually Egyptians had used electrical stimulation over 4,500 years ago, and even the Greeks and Romans had
Wow.
used this. And that involved the use of a torpedo fish to really help ailments, things like gout, things like
Interesting.
migraine, because they found that if they were stimulating folks in these different painful areas, once the fish was removed, that they would have this numbing sensation, and the numbing sensation actually felt good, right?
Felt
It was
good.
No more pain, right?
Yeah.
So I think it dates back, but I would say that we've significantly refined it.
Sure,
perhaps,
yeah.
Today, yeah.
Now, I just want to piggyback off that. Is that what it feels like? If I have a spinal cord stimulator, did I replace pain with buzzing? Did I replace pain with numbness? Like, what is the sensation like?
It's a very good question. In some instances, yes, and people like that buzzing. We call that paresthesia based.
Yeah.
In other instances, the frequency is very high, or it's in that burst kind of delivery, or it's in differential targeted multiplex forms where, again, it's very subtle. It's subthreshold. You're not really noticing a lot.
Sure.
And so it's whichever the patient responds to the best, and that's the importance of that trial feature. One can do very, very well. It's important to note that some people like that numb part, and so it's significant because I think there was this movement away from that and saying,
Sure.
hey, can you do stimulation pattern where I'm not feeling that? I don't want to feel that.
Yeah.
I just want to feel nothing. I just want to feel better. But the answer is that people are different, and a lot of people actually really do enjoy that. And so, just like a massage chair, if you're changing, do you like heat? Do you not like heat? Do you want to massage your neck? There are different ways in which to do that. That speaking to that is the trials. Normally, when you're locked in with a trial with one kind of company, you tend to go with that, but it's not inconsequential, or not inconsequential, but it's not rare to consider, well, if I failed that trial, may I try another device. Right? And then you can almost have a comparative thing. That's a possibility for some. Yeah.
Now, once the implants are in,
Yes.
right? Can you remove them? Do you just add new leads if they stop to work? Kind of what are the revisions, if you will?
Yeah, yes and yes. So that's the beauty of spinal cord stimulation, because we have to think about things in terms of reversibility, right?
Yeah.
If you're doing reoperation and operation and operation after that, those are irreversible.
Yeah.
Spinal cord stimulation is irreversible. Those leads can slip out and you can remove them.
Okay.
You can either replace the IPG itself. If there's a problem with the leads, yes, you can retunnel and place new leads and a new device altogether. And you could do full explantation. Let's just say, and this has happened in some cases, and we've had that experience at UC Davis where maybe the implants were placed a long time ago. The person had CRPS. they're actually doing much more favorable, and now they just don't want that unit in there anymore. You can explant that, and
Okay.
they could be free of a device.
Nice. What you know, we always get happy with our good patients, right? The people that do well. I think a lot of us dwell on, you know, the not so good outcomes, right? And we try to figure out, okay, why did this happen?
Yeah.
And, you know, prevent it from happening again. How can we improve, right? So give us kind of a home run patient, and then also, you know, things you've learned, pearls for some of the younger clinicians getting into the field, you know, complications or things to look after that, hey, you've learned over the years.
Yeah, so I would say a couple of home run patients, some that may have had a condition called thoracic outlet syndrome. Maybe they've had surgery and they have persistent pain along the brachial plexus region all the way up down the arm. And so we've had success with cervical spinal cord stimulation in ameliorating that type of pain, as well as things like headache or
And so, sorry to interrupt, that's not as frequently used, right? We always talk about lumbar thoracic stimulation, cervical.
Yes, it's not as frequent, but it can be very helpful. And this almost goes into the realm of, the trigeminal cervical complex in terms of facial pain, head pain, because they all originate. A lot of these are projections off of that spinal cord. We talked about that somatotopic representation.
Sure.
And there's a lot that occurs at that higher cervical level. So there is the ability to stimulate there and not only help with, head pain and things of that nature, but also upper extremity pain. So I would say that would be one slam dunk. Another was like the CRPS, from unfortunately a Epstein-Barr virus / response to medication / surgery, and then the person had developed, postoperatively complex regional pain syndrome. So we were able to use, in that case, dorsal root ganglion stimulation because it was solely foot pain.
Gotcha.
That was yet another success. And then just numerous other elements of great well-being in folks that receive therapy. There have also been some not so good.
Oh, yep, it happens. Yep.
Yeah, and I would say that largely that's where patient selection is also important, and then also just a learning experience, as I mentioned, right? Like being humble and understanding that you really have to be intuitively prepared for everything. And early on, like sometimes we misplace the leads, or the leads thread through the spinal column, including the neuroforamen, or where the spinal nerve roots exit. And so, one can get stimulation not where they're expecting to have relief. And that's because under fluoroscopy, if you're not paying attention, if you're not midline, the lead can travel and then thread in, and that could be incredibly painful for the patient. Fortunately, you can remove that and
and fix it.
Yeah.
Now,
that's an example.
Yeah, my background's more, we're both PM&R, but I'm more of a sports guy. I do some spine as well. Everything I do typically is accompanied by some sort of physical therapy or exercise program. With this, does that matter? Do they have to actually be more limited with physical therapy because of the implant? Where does physical therapy, or that component fit in here?
I would say pre and even after. It's just being cautious in the after.
Okay.
And usually, people with neuropathic pain conditions, they would derive great value from a physical therapist that really understands pain neuroscience education. So it's really understanding, the mind, how the mind works, perception, prevention of things like kinesiophobia, like fear of movement, because we want these folks to move. They've just been debilitated for so long. So physical therapy is a large part of the improvement. And by the way, a lot of these people, if they have failed back syndrome, they may be suffering from things or experiencing things like adjacent level syndromes and all of these other things that come with it. So therapy is incredibly important
Okay.
to maintain.
So it's
throughout.
still a part of it.
Still a part of it.
All
Very
right.
big part of it. Yeah.
Well, good. I'm glad to see that, you
Yeah.
know, the PM&R is still involved.
Yes. Yeah. Very much so. Yeah.
All right, great.
Yeah.
Well, we don't want to take too much of your time. Let's stop here for spinal cord stimulation.
Sure. Yeah.
We're going to continue on with peripheral nerve stimulation.
Okay. Yeah.
So obviously maybe talk to us a little bit about the difference, right? Peripheral versus spinal cord stimulation and kind of how these patients differ.
Yeah, so the spinal cord stimulation is really at the level of the central nervous system, which is basically the spinal cord in the brain. Peripheral nervous system is any peripheral nerve outside of that. And so most of these peripheral nerves, ultimately, they will come as ascending and heading toward the dorsal root ganglion, which I mentioned is just right outside of that spinal cord. So this can be largely useful for things that occur in the periphery. So for example, if you have a knee surgery and then there is problems where maybe the genicular nerve got damaged or those kinds of things, people can treat that peripheral nerve using peripheral nerve stimulation, or the femoral nerve, right? Sometimes people are getting back surgery and maybe they're positioned in a certain way and the femoral nerve might get compressed or injured in a certain, stretched in a certain approach. These are elements of where peripheral nerve stimulation may make more sense. Post-hemiplegic shoulder pain, where there is subluxation, perhaps there's injury or effect to the axillary and suprascapular nerves is another indication where PNS, as they call it in the acronym, can be very, very helpful.
Okay. So aside from, obviously where the lead goes, is the technology or the science the same? Like, is the lead doing the same thing at the peripheral nerve than it is at the spinal cord level? Or is it a different, theory altogether?
It's slightly different, and it can change depending on the type of device used, but more or less, it is similar. You're trying to jam or intercept the pain signals near the nerve. Some of the devices, the lead has to be fairly close to the nerve, right on it, if you will. Other devices, there's a lot of give.
Gotcha.
And, there's a lot of,
Okay.
so.
But the lead itself is much smaller.
Much smaller.
Okay.
Some say like a piece of angel hair pus,
Yeah.
a filament, if you
A
will.
filament.
Yeah.
Now, I think something to note is with the spinal cord stimulator, that's a permanent implant.
Yes.
Peripheral nerve stimulator is always a temporary, typically about 60 days. So
Yeah,
tell us a little bit about that.
Yeah, let me unpack that a little bit. So yes, in fact, there is what we call temporary percutaneous peripheral nerve stimulation, which is a 60-day treatment, and that at end of treatment, that is removed, and then you can then just be free of any device.
Got it.
So that is a system that has been very useful for people with shoulder pain and other debilitating conditions. There are others that are fully implantable, and in fact, they follow the very similar pattern for spinal cord stimulation.
Yeah.
So you would do a trial with simply the lead in and an external device. What's very interesting and fascinating about the permanent, not percutaneous temporary, but the permanent peripheral nerve stimulation devices are that they communicate. Sometimes they're just simply the lead, with a little bit of an antenna or the back part that communicates with an external pulse generator that is used or worn around a brace, for example.
Got it.
And it communicates through radio frequency.
Interesting.
Others have a little bit of a hockey puck, or that external pulse generator is outside, so they're leads with very small implantable pulse generators which go underneath the skin, but they also communicate remotely with the device worn on the exterior. Yeah, and you don't have to wear those 24 hours a day.
Sure.
So you can receive stimulation and then get a very good result. Still, yeah.
So, in my training, a lot of times we would do a diagnostic block around the nerve to see if the pain gets better.
Yeah.
Do you think that's absolutely necessary to do before doing an implant, a peripheral nerve one, or
Yeah.
is it more clinical indication and like, hey, I'm pretty sure this is it, let's go for the implant?
Yeah, so some would argue that it's not a must-have,
Sure.
it's a nice-to-have. However, I see the value in actually doing that for several reasons. One is you get insight, a 50,000 square foot view as
Yeah.
to, hey, how is this nerve looking?
Sure.
How is it responding? Where exactly is maybe the compressive neuropathy, or where does it look pretty upset?
Yeah.
And then I'll know where to stimulate, so you'll have an understanding. And then you can use a chemically, we call it a chemical block, but basically something like lidocaine, ropivacaine, bupivacaine, just to see if there is in fact pain relief along that distribution of that peripheral nerve. So it can be very helpful.
Okay. What about in terms of choosing between a cortisone injection around the nerve,
Yeah.
a nerve hydrodissection,
Yes.
and a peripheral nerve stimulator? How do you go through that
Oh, that's
that decision-making process?
It's a very, very good question, and I think when I think about it, I often think about, is there an entrapment? Is there a true compressive neuropathy? And are we able to hydrodissect? And hydrodissect, basically placing fluid in and around, breaking up that fascia, moving it away to really help the nerve feel happy, if you will.
Yeah.
Cortisone getting close by and shooting a little inflammatory around there too to see if it can help. So I would say that, really for me, is there truly that dense neuropathy? Is there EMG findings showing that there is in fact damage to that singular nerve? Is there, for example, no more nerve and there's just neuroma because it's a phantom limb? I start to jump more toward peripheral nerve stimulation if I see that discrete nerve damage. If it is sort of, I'm not doing so happy, it's like a carpal tunnel, I'm feeling unhappy, and maybe I just need a little bit of hydrodissection or, to
Cortisone.
free it up.
Yeah.
Pull it. I will go ahead and do that route of treatment and care. So that would be the distinguishing feature for me, is like a dense neuropathic mononeuropathy, nerve damage, peripheral nerve stimulation makes sense, especially if it's after a surgery.
Got it. And image guidance wise, are you going ultrasound? Are you going fluoroscopy?
Yeah.
And then the other question I have to that is, are you going, are you trying to lay the lead down on the nerve, or are you going across the nerve?
Yeah, it's a very good question, and these are all things that we struggle with and we think about and we perseverate on.
Yeah.
And I would say to you, in terms of guidance, usually dual guidance, but I tend to prefer ultrasound. The fluoroscopy is meant mainly for my clinical representatives so that we know where the lead is.
Got it.
That when they're reprogramming, we have a bird's eye view of where things are. But really, the nerve you can actually see under ultrasound. It's beautiful. It's such a beautiful thing to be able to see. In terms of lead placement, really it varies. I've had cases where I could see the fascicles of the nerve, and really, if you think about a honeycomb appearance, that's what nerves look like in cross section. So some of the damaged fascicles may look bigger and swollen. They're dark and black. And so if you lay the lead around, almost like a snap bracelet around that area where the electrodes are around that damaged portion, people could get significant relief in that cross section. If you're going parallel to the nerve, that can help too in terms of stimulating based on the device that is utilized and the number of electrodes and the spacing of those electrodes. Those become important contexts in terms of. And then some even will place it somewhat obliquely, right, to try to capture a little bit of
both.
right?
Got it.
Or use two leads, right, and flank
okay.
them and so forth. So there's a variety of things that can be done and accomplished, but usually in the trial period, that's where I have an idea or sense of where I'm going to permanently place the final and hope to emulate or replicate the positioning. That said, with the temporary percutaneous device, it's very forgiving.
Sure.
So you could be, close enough is good enough.
Yeah.
Diamonds are forever.
Yeah.
Cubic zirconia, they're good enough.
Yeah.
And so if you're good enough, you're near the nerve, you'll be in good shape. You know what I mean?
Love it.
Yeah.
All right, so we've gotten the peripheral nerve stimulator in. Let's say we do the 60-day one, or even some of the more permanent ones. How permanent is the relief? And what is the data showing us in terms of, is it 100% pain relief? Is it 70% relief? So how much pain relief are we getting, and how long is it lasting?
Yeah, it's a very good question, and I would say that if we're talking about the temporary percutaneous nerve stimulation, there's a very nice publication by Pritzloff and colleagues actually looking at endo treatment and following folks that had received this temporary percutaneous nerve stimulation over time, and there is a very great variability in all of that. But roughly speaking, some people can even achieve up to 70% pain relief, even up to a year after you remove it, after end of treatment. So some people are still doing really well. I find in my own clinical practice that those people with shoulder, pain due to post-hemiplegic shoulder pain, or really, arthritis and degenerative conditions of the shoulder tend to do really well. I use it in application for low back. Say they're not a candidate for vertebral augmentation, or they have really bad back pain. You can really utilize that in terms of stimulating the multifidus. And if you think about the nature of a healing vertebrae, removing it at the time, after the course of treatment, and then people are good, right? Like afterwards.
Yeah.
So using it in the paradigm of which you're utilizing it can be beneficial. Permanent implantation also can be very successful. The caveat is, as you mentioned, over time and very similar and analogous to spinal cord stimulation, there is going to be neuroplastic changes. There are limitations to peripheral nerve stimulation. Some of those include things like lead migration, right? Especially if you're crossing a joint.
Yeah.
There's also lead erosion that's possible, lead fracture. So these are not inconsequential, and these could really reduce the efficacy or the long-term improvement. But for the most part, again, if we fashion ourselves into those principles of appropriate surgical technique, appropriate placement, appropriate follow-up, we can mitigate a lot of those risks.
And it sounds like, let's say that I did well with one, but then the pain comes back. It sounds like I can just put in another one. It would be fine to do that.
You can. I would say that what may be difficult, and this always is the case, is revisions.
Yes.
Revisions are always hard, right? Because those permanent ones, as an example, they may have what are called tines, and tines secure that in place. And over time, there's tissue that forces. So you're trying to pull out a spaghetti noodle, or something that's in there pretty tough. And so it may take a little bit of effort, but you can have success with the revision, absolutely.
Got it. And it sounds like that might be something for patients to know, right? That
exactly.
Even though it's meant to be a removable noodle implant, it may be permanent because we can't get it out.
It may be permanent because we can't get it out, and we may need to stimulate now at a different location because of changes that have occurred over time. I'd like to also caution that most of these are FDA indicated for peripheral nerves. Now there is also the possibility for treating craniofacial nerves in terms of FDA clearance for one device company that you're able to actually implant in the face, because we have a lot of people with, facial pain.
Sure.
And they suffer.
And it's brutal.
Quite a great deal.
Yeah.
And they had no other options, and now there is this opportunity to be able to do that. So this is again, I talk about the progress that we have, and this is yet another example of that.
Where do you see this technology going? Right, it's relative. I would say peripheral nerve stimulation is newer than spinal cord stimulation.
Yeah.
Where do you see it going in the next few years?
Yeah, I see it earlier on. I see it used in a way where we can really start to help people faster and sooner. And I think with the use of machine learning and integration, patient monitoring strategies, I think we'll just refine the relief that people experience over time. So it's not like this one and done. You forgot about the patient forgot about you, it doesn't seem to work. There's now more communication, and I hope that this day and age, with all of this technological advances, that we're able to communicate better with patients through remote monitoring.
Got
Because
it.
as you know, it's just so hard to get into medical care nowadays. So this is one means by which we can provide effective therapy. And again, that closed loop seems to be very helpful in that capacity. I would also say that harnessing energy and using less energy to be able to deliver the same result, if not better, is a refining of the technique, if you will. So I think over the next 5 years, it looks promising for me.
Awesome. Well, thank you so
Yeah.
much. This was awesome. Very good learning experience for me.
Yeah.
I hope you guys enjoyed it. Again, this is BIOS KOL Sessions with Dr. Charles De Mesa.
Yeah.
Any closing statements? Anything else you want to say?
I just hope this was stimulating
Yeah.
for everyone, as it was for me. I'm just kidding.
Yeah, it was
For real.
stimulating.
Thank you all.
All right. Thank you, guys.